Hello guys and welcome back to Count to 10. My name is Arnie and today we're going to start covering cardiac physiology. The topic we're going to cover today is electrophysiology of the heart. My initial plan was to cover both this and the myocardial O2 supply and demand, but I think that's going to make this podcast too long, so we'll save that for the next time. Now there are two learning objectives attached to today's topic as per Mac 95. One of them really is 5 learning objectives in one, and this will cover the ionic basis of automaticity, how a cardiac excitation process occurs, and looking at the action potential. And if you haven't already done so, look at my previous mini pod where we discussed in detail the action potential of the cardiac myocyte versus a pacemaker cell. We'll do a quick recap again on this podcast, but in my mini pod we really went into detail comparing and contrasting the two different types of action potentials. This is a very content heavy podcast as it's the initial introduction to cardiac physiology, and then, as always, to finish, we'll look at the previous SAQs. So with that said, let's dive straight in.
1, 2, 3, 4.
Now, the first learning objective is discuss the physiological basis of electrical activity and its relationship to the mechanical events, including the ionic basis of automaticity, the physiological basis of the ECG, factors that may influence the cardiac electrical activity, and then correlation of the mechanical events of the cardiac cycle with the electrical and ionic events. So it's a jam-packed first learning objective, and to begin, we'll start off with the ionic basis of automaticity. Some simple definitions, but some important definitions to remember, is what is automaticity. This is the ability of the heart to generate and initiate its own beat, while rhythmicity is the regularity of a pacemaking activity. Together, these are properties that are intrinsic to the cardiac muscle. The ionic basis of cell action potentials refers to how action potentials are associated with changes in permeability of a cell membrane, typically to ions that include sodium, calcium, and potassium. Changes can occur because of both opening and closing of certain ion channels, and these can be linked to voltages or independent of voltages. So, the resting membrane potential is a core term that you must know, and the creation of the RMP is mainly due to the equilibrium potential of potassium. Now, how do we know that? This is because the cell membrane is very permeable to potassium, unlike sodium or calcium. There are two main forces that regulate potassium movement across a cell membrane. The first is the chemical force, and the second is the electrostatic force. The chemical force is based on a concentration gradient. Mainly, there's more potassium inside the cell, so potassium wants to go outside the cell. The electrostatic force is based on the electrical activity across the cell membrane. Now, as you know, inside of the cell membrane is more of a negative charge, and outside is a positive charge. Now, using the Nernst equation, we can express what the equilibrium of those chemical and electrostatic forces would be for a particular ion. So if we plug into the Nernst equation potassium, we get a number that's equal to minus 94 millivolts. Now, this is a key number to remember because when you look at a cardiac myocyte cell, the RMP is roughly minus 90 millivolts. Because these two numbers are pretty close to each other, we can say that the main factor that's causing the RMP to be minus 90 millivolts is potassium, and that's why we can go back and say that potassium is the main determinant of your resting membrane potential. That's really as simple as you need to keep it in terms of understanding the ionic basis of automaticity. Now, if we look at the normal and abnormal process of cardiac excitation, i.e. the action potential, we can delve into how these ion levels change through the normal action potential cycle for both the cardiac myocyte cell and the pacemaker cell. So just as a recap, there's two types of action potentials within the heart. There's the fast action potentials from the atria, ventricular myocytes, and specialized conducting cells, mainly the Purkinje fibers. And then there's the slow response action potential. These are the ones you see in the SA node and the AV node. The classical fast response action potential has 5 phases attached to it, and you need to know each one by heart and be able to draw them really quickly for a Viva. So phase 0 is the initial rapid depolarization. This is when you go from your RMP of minus 90 millivolts and have a massive positive upward spike. This occurs because there's fast voltage-gated sodium channels that have opened, typically when you reach a critical potential value of minus 65 millivolts. Here, the influx of sodium is so high and so fast that for a brief period of time, you actually get a positive charge up to positive 20 millivolts. This is called overshoot and is the transition to phase 1 of the action potential. Phase 1 is the partial repolarization, where we have transiently outward voltage-gated potassium channels being activated. At the same time, we're getting inactivation of those initial fast voltage-gated sodium channels. So as that action potential starts to come back down and go closer to zero, that's when we reach phase 2. Phase 2 is the plateau phase. It's a unique feature of these fast response action potentials, and it's what separates them from the slow response action potentials. It's caused by the influx of calcium through partially T-type calcium channels, but mainly L-type, i.e. long-lasting calcium channels. Now, if you remember from the mini-pod, these channels actually open in phase 0, but they take time to open, and that's why you can see the effect in phase 2. Sometimes in your vivas, people like to quiz you on that fact, just to see what your depth of knowledge is. Then we go to phase 3, which is the repolarization phase. So here, our action potential is slowly coming back down to its RMP, and it's doing that via the fact that more potassium channels are opening. Now the potassium is exceeding the influx of calcium. There are a myriad of potassium channels that you must know of. These include the delayed rectifier and the inwardly rectifying potassium channels. And as confusing as it sounds, they're not actually putting potassium into the cell, they're taking potassium out of the cell. Remember, potassium is a positively charged ion, so you want to remove it out of the cell so that inside the cell becomes more negative. This is providing the counterbalance between the calcium and the potassium. Then we finish off and reach phase 4. Phase 4 is when the action potential reaches its resting membrane potential again and goes back to minus 90 millivolts. During this phase, there's restoration of the ionic concentration, and these are done by 4 important channels. The first one is the NAK ATPase. This pushes 3 sodium out and 2 potassium in. Then there's the Na calcium antiporter. Here, this pushes 3 sodium in and 1 calcium out. Then we have the calcium ATPase. This allows calcium to go out of the cell. And then finally, we have the potassium inward rectifier. This allows potassium to go out of the cell. The other important part of this fast response action potential is that its total duration is roughly 300 milliseconds. Its absolute refractory period is 250 milliseconds, and this is really important because we don't want another action potential to be initiated until that ionic basis has been restored. Because if you don't have that long absolute refractory period, what you'll get in the heart is tetany, and that's exactly what you don't want in your most important muscle of your body. Now moving on and looking at the slow response action potential, so these are the action potentials of the SA node and the AB node. These are quite unique and different to the cardiac myocyte ones and the fast response action potentials. The first main difference you'll see is that the shape of the action potential is more like a triangular upslope compared to that plateau phase. There's 3 distinct phases compared to the 5 distinct phases, and in some books you might have 4 phases, but I have 3 in my notes. The first phase is actually phase 4. This is the pacemaker potential. Unlike the fast response action potentials that have a RMP, here in the slow response action potentials, there's no RMP. And what this means is that there's no real resting state. This is important because this is what goes back and gives the heart its automaticity and rhythmicity. Here, if you had to say where the RMP would be, if you had to draw this, you'd say it'd be probably around about minus 65 millivolts. You have ongoing slow spontaneous discharges, and when that discharge reaches a threshold of minus 40 millivolts, this is when you get the action potential occurring. This leads to phase 0, which is the depolarization phase. This is caused by L-type voltage-gated calcium channels, so the long-lasting calcium channels. To get the cell from its minus 65 millivolts to the minus 40 millivolts, there's the importance of T-type calcium channels that are opening to raise that RMP. Then you have phase 3, so you miss out on phase 1 and phase 2 in the slow response action potentials. Phase 3 is the repolarization phase due to the efflux of potassium by the delayed rectifier potassium channels. Now, knowing the ins and outs of all the names of the potassium channels with these slow response action potentials is less important, but more important for your fast response action potentials. It's very hard to find out in any text you read what these channels are called in your slow response action potentials, so I've just left it and called it the delayed rectifier potassium channels. Now, when you compare these two slow response and fast response action potentials, you'll actually find that the duration is very similar. They're both approximately 300 milliseconds, but their shape and their phases are much more different. The other main difference is the conduction velocity of each one of these types of action potential. The slow response can be anywhere between 0.02 to 0.1 meters per second, while in comparison, the fast response action potentials in the myocardial cells can be between 0.3 to 1 meters per second, and actually in the Purkinje fibers, they can be as fast as 4 meters per second. Again, that's a small fact, but people like to ask it in a viva setting. Now, there's a lot more differences between these two types of action potentials, and again, we've discussed it in the mini pod previously, so I won't go over it again. But what I do want to quickly point out is what happens to these slow response action potentials with the change with parasympathetic stimulation and sympathetic stimulation. With parasympathetic stimulation, you get increased hyperpolarization of the action potential through increasing potassium into the cell. This extends out our phase 4 and really makes those T-type calcium channels work really hard to get the action potential up to its critical threshold. When you do finally get the phase 0 of these slow response action potentials, it looks like a wider triangle. This is because there's more potassium that's hyperpolarized the cell, so the calcium is having less of an effect and a slower effect to get that action potential to a positive level. In contrast, when you have sympathetic stimulation, the permeability of those pacemakers or the slow response action potentials is greatly increased to calcium. Now that phase 0 shoots up really quickly, almost looking like a phase 0 from the fast response action potentials. As well, you get a shortened phase 4 because those T-type calcium channels are more excitable, so there's more calcium going into the cell. So the key thing to remember is that parasympathetic stimulation makes the triangle look fat, while sympathetic stimulation makes the triangle look skinny. The peaks of the triangle doesn't change regardless of parasympathetic or sympathetic stimulation. Now let's move on and talk about the second part of this mammoth learning objective, which is the ECG. An ECG is an investigation we see on a daily basis with pretty much every patient. The information an ECG provides is that of the orientation of the heart, the size of its chambers, the rhythms, any ischemia, if there's any electrolyte disturbances, and the effects of drugs. What we use for an ECG is a scalar electrocardiography. This is a recording of changes with time of the differences of potentials between 2 points on the surface of skin. The standard 12-lead ECG detects small potentials of 0.5 to 2 millivolts at the skin generated by the spread of electrical activity within the heart. Now, when you look at a 12-lead ECG on a recording paper, there are certain set calibrations. One large box is equal to 5 millimeters, one small box is 1 millimeter. The speed of an ECG is typically 25 millimeters per second, so this means that one large box is equal to 0.2 of a second. The height of an ECG is standardized, where 2 large squares equals 1 millivolt. So therefore, with that calibration, you can say that one large box being 5 millimeters is equal to 0.2 seconds wide and 0.5 millivolts high. Why are these numbers important to know? Well, knowing how long each box is helps to identify any kind of arrhythmias or heart blocks, while knowing the size and the voltages helps to diagnose any kind of ischemia or hypertrophy. The other important thing about the ECG is knowing where the leads are being placed. If we know where the leads are being placed, we know where the vector through the heart is going. and therefore we know which way the heart is looking at. So if we know that, we can figure out the axis of the heart, and to break it down really simply, a normal axis lies between -30 to 90 degrees. And when your heart lies within the normal axis, lead 1 and AVF are both positive. Now, I'm not here to give an ECG tutorial as this would take way too long, but it is important that we know what the waveforms are on the ECG. This may seem like some medical school knowledge, but you'd be surprised how many people are Viva and they still get this wrong. So on an ECG, the first upward deflection you get is the P wave. This is atrial depolarization. A normal P wave should be less than 3 small boxes wide and less than 2.5 small boxes tall. Then after the P wave, the ECG returns to isoelectric. This is referred to as the PR interval before the QRS starts. A normal PR interval should be less than 0.2 milliseconds. So this is 5 small boxes or 1 big box. This delay is inbuilt for purpose so that all of the atria, both the right and the left side, are depolarized and contract into the ventricles. Then we have the QRS, which is ventricular depolarization. A normal Q wave should be less than 1 small square wide and less than 25% of the QRS complex. Within the QRS, atrial repolarization is buried, so therefore you never see it. Then, following the QRS, you have a return to the isoelectric, which is the ST segment, followed by the T wave. This is ventricular repolarization. Now, just to throw out some other important numbers, a normal QRS should be between 0.06 to 0.12 milliseconds. So this is a maximum of 3 little boxes. The normal QT interval differs between males and females. In males, a QT should be less than 440 milliseconds, and in females, less than 460 milliseconds. And what's more important is not actually the QT, but the corrected QTC, because this correction accounts for the change in the patient's heart rate. So the QTC can be calculated using commonly Bizet's formula, which is the QT divided by the square root of the RR interval. The one quick note I do want to make about the ECG in terms of anesthetic implications is the reason we use lead 2 is because of the way that it can visualize the P wave. Because the P wave is a representation of the atrial depolarization, and atrial arrhythmias or dysrhythmias are the most common complications with an anesthetic, this is easily recognized with monitoring lead 2. So moving on from the ECG, we have to talk about the factors that may affect the cardiac electrical activity. And to talk about this, we first must understand where the electrical activity gets generated from and the pathway it goes down. So the first place is the sinoatrial node. This is the remnant of the sinus venosus, and it's in the groove where the SVC joins the right atrium. The normal SA node discharges at 100 beats per minute. And because we know that our normal resting heart rate is roughly 60 beats per minute, we must know that there's an ongoing influence by the autonomic nervous system that's dampening down the SA node activity. The SA node cells transmit their signals via gap junctions. Through this, the impulses spread through the atria at a speed of 1 meter per second. They go from the right atrium to the left atrium via the Bachmann's bundle. This ensures both atria contract together, and to make sure this is a synchronous process, we have the PR interval. The PR interval is generated because of the unique features of the atrioventricular node. This is the node that's located posteriorly on the right side of the intraatrial septum. It's surrounded by the coronary sinus and the tricuspid valve. The unique thing about the AB node is that it has 3 functional regions. The first region is the AN region. This is the atria to the nodal region. This is the transitional zone between the atrium and the remainder of the node. Then we have the N region, or the nodal region. This is the mid portion of the AB node, and the conduction speed here is the slowest within all of the heart itself. It is 0.05 meters per second. Now this difference between the AN and the N regions is the principal reason why the delay of the passage of impulse occurs. As we age, within these two regions, deformities occur and pathologies begin. And this is when people can go into a heart block. Then, to complete the AV node, you have the third functional region, which is the NH region. This is the nodal to the His region. So these are the fibers that connect down to the bundle of His. The key thing about the AV node is that it's the only pathway in the person that has an otherwise normal heart down to the ventricle. So therefore, it's the gatekeeper to the ventricle. So then following on from the AV node, we have the bundle of His. This bundle passes subendocardially down the right side of the intraventricular septum for approximately 1 centimeter, then divides into the left and right branches. The left branch has an anterior and posterior division, while the right branch just has a single division. As the branches reach their terminal end, they subdivide into a network of conducting fibers called the Purkinje fibers. The unique thing about the Purkinje fibers is that they actually have the largest diameter of cells in the heart and therefore allow for the fastest conduction velocity up to 4 meters per second. And again, this logically makes sense because you want those Purkinje fibers to quickly wrap around the ventricular myocytes and cause that contraction to occur. And when those Purkinje fibers depolarize and activate the ventricle, they activate from their apex up to the base, and this helps to propel the blood up. Specifically in the left ventricle, you get a corkscrew motion, which is why the left ventricle is so effective at pumping against a high resistance system. In contrast, the RV is much thinner, so if you get a high afterload, the RV is very prone to decompensate with any rises in afterload. So this leads to a great segue to see how the ECG and the electrical events correlate with the mechanical events. To understand this, we first need to know what a cardiac cycle is. A cardiac cycle refers to the period of muscle relaxation and diastole and a period of contraction known as systole. The typical length of a full cardiac cycle is approximately 0.8 seconds. 0.5 of that is diastole and 0.3 of that is systole. So with a normal resting heart rate of 60 to 70 beats per minute, ventricular filling can account for 2/3 of a cardiac cycle. Now when someone gets tachycardic up to 100-150 beats per minute, you shorten that cardiac cycle down to, say, 0.3 seconds, and each phase is reduced. So looking in these two phases more in detail, systole and diastole, we can subdivide each one of these even further. If we start with systole, the very first phase is isovolumic contraction. This correlates with the R wave and the first heart sound that you hear. During this time, the AV valves have closed, but the aortic and pulmonary valves have not yet opened. Here in the heart, what we're getting is a rise in the pressure within the ventricular chambers, and this rise in the pressure is actually causing the AV valves to bulge into the atria and correlates with the C wave that you see on a normal CVP trace. The pressure within the ventricle will continue to rise until it exceeds the pressure outside of the ventricle. This is the stage when the aortic and the pulmonary valves will open. And this leads us onto our next stage of systole, which is the rapid ventricular ejection. Here, the ventricular pressure is greater than the aortic pressure, and you get a rapid ejection of blood from the ventricles. At the same time, the contraction of the ventricles pulls the AV valves down, increasing the atrial volume and causing the sharp X descent that you see on the CVP trace. Following the rapid ventricular ejection phase, you get a reduced ventricular ejection phase. This is where both the ventricular and the aortic pressures start to decrease. However, blood continues to eject out of the ventricles due to the momentum created in the initial rapid ventricular ejection. At this stage, blood is starting to reaccumulate within the atria, and you get the subsequent V wave in your CVP trace. At the end of this reduced ventricular ejection phase, the pressure within the ventricle will be lower than the pressure outside of the ventricle, and so therefore the aortic and the pulmonary valves will close, leading to the second heart sound. The important part at the end of this stage is that not all of the blood has been ejected out of the ventricle. Approximately 50 to 60 mils stays within the ventricle, and this is why our normal ejection fraction is not 100%. The reason we have this amount of blood left in the ventricle is it allows it to be a buffer for a changing of both the heart rate or the resistance to the outflow tract. Now we get to the first stage of diastole. The first stage of diastole actually begins with isovolumetric relaxation. Here, the semilunar valves have closed and we've seen an aortic notch or the incisura within the aortic trace. In this phase, the pressure within the ventricles is rapidly decreasing, however, it still remains above the pressure within the atria. Remember, the pressure within the atria is very low. In the left atrium, the pressure reaches a maximum between 5 to 10 millimeters of mercury, and in the right atrium, this can be between 2 to 5 millimeters of mercury. So, for those AV valves to open, you really need the pressure within the ventricles to drop down significantly. Once it reaches that threshold, you get the next phase of diastole, which is the rapid ventricular filling phase. Here, the AV valves have opened, and this correlates with the wide descent on our CVP trace. And during this rapid ventricular filling, nearly 75% of the blood can be filled into the ventricle under normal conditions. After the rapid ventricular filling phase, you get the slow ventricular filling phase. This is approximately mid-diastole. Here, both the atrial and ventricular pressures are both low, and there's still passive filling of the ventricles occurring. The last phase of diastole is the atrial systole. This is when the SA node discharges and our ECG trace starts. This corresponds with our A wave on our CVP trace, and in normal settings, this contributes 20 to 25% towards ventricular filling. When we get pathological states where the ability of the heart to relax is compromised, known as diastolic failure, this atrial systolic phase or the atrial kick becomes more and more important and contributes a higher amount to the filling of the ventricle. This is why you'll hear in patients with aortic stenosis who typically develop this diastolic failure, maintaining a sinus rhythm is key because it allows for proper filling of the ventricle. So these are a lot of steps that I've just discussed, and a quick summary is that systole begins with isovolumetric contraction, followed by a rapid ventricular ejection, then a reduced ventricular ejection. Diastole begins with isovolumetric relaxation, followed by a rapid ventricular filling, then a slow ventricular filling, then atrial systole, also known as the atrial kick. When you're looking at a CVP trace, what you're looking at is just those components that we've just discussed about. The A wave is the atrial contraction, the C wave is the bulging out of the atria because of the isovolumetric contraction, the X descent is now the ventricle opening up, followed by the V wave, which is the atria filling back up. The Y descent is the atria giving its blood back to the ventricle, and then you go back to the A wave being the atrial systole. Correlating that with the ECG, the R wave represents when isovolumetric contraction occurs. Then you have the remainder of the QRS correlating with the ejection of the blood out of the ventricle, followed by the T wave, which is representing the isovolumetric relaxation. So midway through the T wave is when diastole starts, and then the R wave is when systole starts. That is the first mammoth learning objective covered, and now we're going to move on and talk about the second learning objective, which is describe the physiology of cardiac muscle and the mechanism of excitation-contraction coupling. So what do we actually mean when we say excitation-contraction coupling? To define this, we can start off by defining what contractility is. Contractility is the intrinsic level of contractile performance that is independent of loading conditions. In simple words, it's the ability of the heart to generate a force or a power that is independent to the preload or the afterload. The unique thing about the myocardium is that it functions as a synctium. What that means is that it's an all or none response when excitation occurs. Because you don't want a heart that will only half contract. You want a heart that will fully contract every time or not contract at all. So when we look at the myocardium at a microscopic level, you can see that the myocardium is made up of myofibers. These are groups of cardiomyocytes within the extracellular matrix. As you'd expect, there's more cardiomyocytes within the ventricles. These cardiomyocytes, compared to other cells, have a high amount of mitochondria and have a very high O2 demand. We'll talk about the O2 demand specifically in our next podcast when we look at myocardial O2 supply and demand. The key word you have to remember when talking about the heart muscle is a sarcomere. A sarcomere is a basic unit of contraction when it comes to the heart. A basic sarcomere is made of two filaments, a thick filament known as myosin and a thin filament known as actin. Actin filaments slide along the myosin, causing cross-bridging, which then causes contraction. Now, to function as a CICM, all of the cardiac muscles contract together, and this can be done because they're connected via intercalated discs. These intercalated discs each contain gap junctions. This is what allows the impulse to be propagated across the myocardial myocytes. The current which is coming down from the bundle of His through the Purkinje fibers is finding its way down into the cardiomyocytes through invaginations known as T-tubules. These T-tubules run along the Z lines of your sarcomere, and their primary function is to start the process of excitation-contraction coupling. Now, excitation-contraction coupling isn't a tricky process. We've already described the first step, which is that the action potential arrives and then goes down the T-tubules. The second step is that action potential now causes voltage-gated L-type calcium channels to open up. Calcium goes into the cell via dihydropyridine receptors. This is why we have calcium channel blockers that are non-dihydropyridines, such as those on smooth muscle, and dihydropyridines, such as those that affect the heart. And this calcium that goes into the cell alone is not enough to start or activate a contraction. However, what it does is it triggers a large release of calcium from the sacroplasmic reticulum via the ryanodine receptors. This is where mutations can occur, such as those seen with patients with malignant hypothermia, that cause an uncontrolled release of calcium that leads to sustained contraction. The reason why malignant hypothermia does not affect the heart is because its ryanodine receptors are different to the ones that are in the skeletal muscle. This overall process, where calcium release via the L-type calcium channels causes more calcium release via the sacroplasmic reticulum, is called calcium-induced calcium release. The net effect is that the calcium within the cell increases by 100-fold. Now, this calcium is enough to start the contraction. What it does is it binds to troponin, and specifically troponin C. This troponin sits on the thin filament, which then alters the troponin-tropomyosin complex. Think about tropomyosin as the gate that's blocking your entry into the heart muscle contracting. When troponin C is activated, this opens up the binding site of calcium onto the thin actin filaments. Now cross-bridging can occur. Normally, the myosin head can't bind to actin because it's inhibited by troponin I. But here, with the activation of troponin C, that binding site is exposed. Now, with that actin site exposed, the myosin head binds to it and creates a motion called a power stroke. After that power stroke is complete, the calcium no longer binds to the troponin C, and the troponin I regains its inhibitory effect across the actin-myosin interaction. Now, if you're confused about the troponins I mentioned, there are three types of troponin. Troponin C, which is the one that binds to calcium and exposes the actin site. Troponin I, which is the inhibitory troponin. And then troponin T, which is a stabilizing troponin, which stabilizes the complex of troponin to tropomyosin. Simple, right? Well, at least relaxation is a lot more easier to understand. For a cardiac myocyte to relax, at the end of systole, calcium needs to go out of the cell. The way calcium goes out is through those channels that we spoke about earlier. We have the 3-sodium 1-calcium exchanger. We have the calcium ATPase, which puts calcium back into the sacroplasmic reticulum so it can be recycled. And then we also have an active pump that also pumps calcium back into the sacroplasmic reticulum called a SAQs pump. Now, a good question to ask at this stage is, why do I need to know this, Arnie? Why do I need to know all these little steps in detail? Well, the fact is, if you know these little steps, you can know how to manipulate the contraction of the heart, therefore manipulate the inotropy and the lusitropy. Drugs like levosimentan work by altering the sensitivity of calcium to troponin C. Now you get stronger contraction and stronger inotropy, while drugs like calcium channel blockers stop the calcium influxing into the cardiac cell, so they decrease or cause a negative inotropic effect. Other drugs like digoxin, which are cardiac glycosides, they alter the pumps that lead to the equilibrium of calcium and sodium within the cell, leading to more calcium within the cell, therefore increasing the inotropic effect. So while you might think this is really basic knowledge, and you might try to avoid learning it, what I can tell you from first-hand experience is that I was shown a diagram of excitation-contraction coupling in my actual viva on the day with the channels and asked to show where the different types of drugs had an effect on the inotropic effect of the heart, the lusitropic effect of the heart, and the chronotropic effect of the heart. So while I too thought this was not very useful stuff, luckily when I had learnt that digoxin works by increasing intracellular calcium by inhibiting the sodium-potassium ATPase pump, and that increase in sodium intracellularly impairs the sodium-calcium exchanger, which is what leads to the calcium concentration being increased within the cell and therefore an increased force of contraction, I was very happy when the examiner asked me how to describe this in the exam. And I'm telling you, I did multiple practice vivas where they wanted to know exactly how digoxin worked in its inotropic effect. So that brings us to the end of our learning objectives, and now we'll look at some of the past SAQs. The most common SAQ that's been asked, and the last one to be asked, was describe the ionic basis of automaticity in the pacemaker cell of a SA node. This was asked in 2022 with a 61% pass rate, and despite it previously having an 85% pass rate in 2020, was repeated again. So that just shows that this is a fundamental concept that the examiners will keep asking despite high pass rates. The examiner report here stated that the common errors included describing the SA node action potential incorrectly, imprecise or incorrect definitions of automaticity, factual errors with regards to various phases, referring to phase 4 as having a wandering baseline as opposed to a spontaneous and gradual depolarization. I think that's really a nitpicky one. And then simplistic explanation for the factors affecting automaticity. If I had to do my model answer for this question, it would probably follow Ketamine Nightmare's model answer and definitely involve a graph. I'd be very clear with my definitions and start off with saying what automaticity is. So it's the intrinsic ability of the heart to generate its own impulse independent of other factors. The reason why a threshold is reached and an action potential is triggered is because there's constant fluctuation of ions, particularly with T-type calcium channels, as well as these special channels that we haven't mentioned previously that are called HCN channels. You can label these as funny current channels, and that's totally acceptable. This leads to that phase 0, which unlike a cardiac or a fast response action potential, is not a straight uprise, but more of a sloping uprise. The other important thing to recognize with this action potential, which is both unique and a major safety feature, is that the absolute refractory period actually extends all the way into phase 4. So it goes from phase 0 to phase 3 to the start of phase 4. And that's really important because these are the pacemaker cells of our body. So we don't want them to have an abnormal stimulus causing an abnormal rhythm leading to an arrhythmia. Now, the other things that I would also involve in this question is both the factors that increase and decrease the rate of this action potential. These are looking at contrasting features, such as the sympathetic stimulation leads to an increase in calcium, therefore an increase in all the steepness of the slopes. So remember that triangle becomes more narrower. Increase in temperature causes an increase in rate through an increased metabolic effect, leading to more of the enzymes working quicker. And the opposite is also true. And then there are normal physiological changes of why there are differences, such as those with neonates where you have a high heart rate because the heart has a relatively fixed stroke volume. So the only way you can manipulate your cardiac output is by changing your heart rate. And then in the elderly, those conducting systems such as the SA node and the AV node get hit with lots of fibrous tissues. That fibrous fatty tissues lead to the conduction pathway becoming slower and therefore the action potential taking longer to occur. The other variant to this SAQ was asked back in 2016, where the question was compare and contrast the action potential of the SA node and the ventricular myocyte. Now I've covered this in my mini pod, so I'm not going to go over it again. We're going to move on to the next SAQ, which is draw and label a lead 2 ECG trace for one cardiac cycle, indicating normal intervals, values, and then what is the PR interval and what factors influence it. This question was last asked in 2020 with a pass rate of 67%. The major domains the examiners wanted here was an ECG and a diagram of an ECG that was appropriate x-axis and y-axis. That's why it's important to know what the calibration is. So remember, the sweep speed is 25 millimeters per second, and the height is every 10 boxes is equal to 1 millivolt. Then they wanted a description for the physiological basis for the PR interval and its importance, a description and some explanation of the factors that both increase and decrease this PR interval. So if I had to do this question, I would have my axis as a y-axis being voltage and x-axis being time, and voltage would be in millivolts, and time could either be in seconds or milliseconds. It doesn't matter. I'm not going to go through how to draw an ECG trace, but your PR interval should be less than 200 milliseconds. Remember, your PR interval starts from the start of the P wave to the start of the QRS. So it doesn't end with the R wave, it ends with the start of the Q wave. Importantly, you need to have a table with factors that increase, and these can be high parasympathetic activity caused by vagus nerve stimulation, causing a release of acetylcholine. This leads to a decrease in cyclic AMP and a slowing of the conduction velocity. Drugs such as beta blockers, calcium channel blockers, all slowing down conduction velocity. Ischemia or hypoxia. If you can't remember this, think about neonates. What happens to neonates when they become hypoxic when you're trying to induce them? They become bradycardic, so their conduction velocity slows down. And then endocrine things such as hypothyroid. On the opposite side, you can have the increase in sympathetic activity, drugs that are sympathomimetics like adrenaline, endocrine things such as hyperthyroid, and additionally accessory pathways like Wolff-Parkinson-White that can all shorten that PR interval. Now to finish, there are two SAQs from the CICM exam that I think would be very likely to come up in some form or another in our exam. The first one was asked way back in 2010. It was describe the ionic events of the ventricular cardiac action potential, being 80% of the mark, and then outline how the action potential relates to the mechanical events of the cardiac cycle. Now the first part we've covered already, but the second part is a unique twist to it, which I think, related to the learning objectives, is very fair game to be asked. Now how you relate this back to the cardiac cycle can be multiple ways. You could divide it into a table that had all the phases of the action potential, so phase 0, 1, 2, 3, 4, and then say what that relates to in the cardiac cycle. Or you could relate it to the pressure volume loop that we haven't covered yet, but we will cover at a later date, and then just describe it as per where each phase occurs in that cycle. Now what I would say is that phase 0 corresponds well with the AB valve closing and the transition to isovolumetric contraction. Here you get an overlap between phase 0 and phase 1. Then into phase 2 you get the aortic valve opening, and this leads to the rapid ejection phase, followed by phase 3, which is the reduced ejection phase, followed by phase 4, which is now when the semilunar valves close, and this signifies the end of systole and the transition to diastole. This correlates on an ECG to midway through a T wave, as well as just prior to the peak of the V wave on our CVP trace. Now to take this question even further, in 2018 in the CICM exam, they were asked to briefly describe the cardiac events that occur during ventricular diastole. Now I found this a really tricky question, and it took me a while to get my head around what they're actually asking. They didn't specify which cardiac event, So you needed to put in everything. That involved the electrical cardiac events, the mechanical cardiac events, the ionic cardiac events, and the pressure volume loop events. So as discussed, the electrical events relating to the ECG correlate with diastole starting midway through the T wave and then finishing with the start of the R wave, which represents isovolumetric contraction. In terms of the ionic events, this corresponds to phase 4 of our action potential, so where we have our resting membrane potential, followed by the initial start of phase 0. Because remember, electrical activity happens first, then mechanical activity happens second. So that phase 0 causes that mechanical activity to start beginning, and prior to us going into isovolumetric contraction, which is the start of systole, we are still strictly in diastole. Now the mechanical events are those stages that happen during the cardiac cycle. So diastole begins with isovolumetric relaxation. This is when both the semilunar valves and the AV valves are closed, followed by the rapid ventricular filling, when the AV valves open up, then the slowed ventricular filling, followed by the atrial systole, or the atrial kick. Then finally, you would talk about the pressure volume loop, and you'd say that diastole occurs from point D to point B. Don't worry if you don't know what that is, it'll make a lot more sense when we talk about it later on. But essentially, it's the graphical representation from when isovolumetric relaxation starts to just prior to the start of isovolumetric contraction. So that completes all the SAQs, and if you note, there weren't any SAQs on excitation-contraction coupling. I think it lends itself better to Viva questioning rather than an SAQ format, because you can really tie it into the drugs that we use, and therefore really see the candidate's depth of knowledge and the ability to connect two different concepts. Now that will do it for me for today. It's been a long first podcast back. I hope you guys have enjoyed it. I know it's a lot of didactic learning and a lot of information to take in, but unfortunately both cardiac and respiratory physiology are just like that. These are the core topics that we just have to know in and out. My next pod will be covering the myocardial O2 supply and demand relationship. So until then, best of luck with your studying, and I'll catch you next time on Count to 10.